Good morning. My name is Sharona Strong. Thank you for joining us for the COVID-19 update session. Next slide, please. Before we get started with the actual session, we wanted to review some housekeeping items. All lines should be muted unless you are a presenter or a speaker. The presentation will be posted to the GAMIS web portal under Provider Notices. This session will be recorded and posted to the DCH YouTube page. Please enter all your questions in the Q&A box. We will address as many questions as time permits. We will capture all questions and create an FAQ to be posted to the GAMIS site within 2 weeks. Next slide. The mission of the Department of Community Health is to provide access to affordable, quality healthcare to Georgians through effective planning, purchasing, and oversight. The purpose, shaping the future of a healthy Georgia by improving access and ensuring quality to strengthen the communities we serve. And now I will turn the presentation over to Anika Washington from the Department of Community Health.
Good morning, everyone. My name is Anika Washington. I am the Eligibility Policy Manager in the Policy and Compliance section here at the Georgia Department of Community Health. Next slide. So I will be providing updates on the COVID-19 updates as it relates to eligibility. Next slide. As you are aware, the public health emergency was declared in March of 2020. During that time, DCH has continued to maintain eligibility for all of its members with a few exceptions, which include residency, death, voluntary request for closure, or erroneous eligibility determinations. An erroneous eligibility determination is a determination that would have been completed incorrectly by the Department of Family and Children Services, where someone was deemed eligible when they were not. Next slide. We continue to provide two-way premiums for all children enrolled in Peach Care for Kids. However, enrollees, Peach Care for Kids enrollees are terminated on the last day of the month of their 19th birthday. They are not covered under continuous eligibility under the public health emergency. Next slide. Our next steps as we prepare for the public health emergency to end is that we have been planning with defects as we begin to determine how we will review and redetermine eligibility for all of the members that we've currently maintained. Part of that is that each member will have to have a new eligibility determination before we terminate coverage of those currently enrolled due to the maintenance of eligibility. Defects will have 1 year to complete this task, so we are planning with them to ensure that we reach all of our members. Also, we are planning different types of avenues so that we can ensure that we communicate to our members and to be able to receive their current address information so that we can provide them with updates and circumstances regarding their cases. Next slide. And now I'd like to introduce Rebecca Duggar, Director of Program and Community Support.
Thank you so much, Anika. Again, good morning, everyone. As stated, I'm Rebecca Duggar, the Director of Program and Community Supports, but I also have the awesome pleasure of being responsible for our telehealth policy here in Georgia. And so we'll go through a little bit of what we've done here in Georgia, how we will be moving forward after the public health emergency, and some things that you need to be very mindful of as we move forward. Next slide, please. We'll give you a little bit of background. We'll also talk about the public health emergency policy guidance that was put in place. We'll also give you some feedback on what we received during our telehealth survey. And then we'll look at what will happen post-public health emergency, and hopefully we'll have time for some questions and answers. And if not, we'll certainly take those questions and get back to you in a separate email. Next slide, please. So just a brief overview of what is telehealth, because we use that in a couple of different ways, but here in the state, we use it interchangeably with telemedicine, telehealth, telebehavioral health. We look at all of that. And of course, it is the use of technology to deliver health care and the health information or even health education, and of course, certainly from a distance during this public health emergency. Now, one of the things that Georgia does is that we have parity. And what that means is that the reimbursement is equal to that if you were rendering those services in person. Some states don't have that. There's a percentage or there's a different reimbursement methodology. The state of Georgia does not do that. Next slide, please. So the increased interest in use by both providers and members as we began this crisis, we saw where we had to continue to render services. And so, of course, telehealth does that by addressing those barriers to care, including providers that no longer have to drive out to individuals or individuals having to be in crowded appointment rooms and things like that. Again, even the transportation barrier where members could not find transportation to those providers. So it addresses that. We also saw where telehealth was very, very useful in our rural areas and address some of those challenges, such as transportation and mileage and distance to get to those providers. And then we also were able to address the behavioral health stigma, where individuals did not feel comfortable receiving behavioral health services in a traditional setting. They could be in the comfort of their home and they could receive the therapies that they needed. Next slide, please. So a bit of background. Georgia has been very responsive, even as early as 2005, when we enacted the Georgia Telemedicine Act. And so when we did that, we were able to set up some services. We had very specific parameters as to who could perform those services. And then the Georgia Composite Medical Board took it a bit further in 2014 to set up the minimum standards of practice while providing treatment and or consultation. And then they also provided additional guidance in terms of what providers could and could not do as far as telemedicine was concerned. So we've been very responsive to that, and we continue to be responsive. Next slide, please. And so here is the previous model, and I put the slide in here so that everyone could understand where we were. And what would happen is that the provider would be in a hospital or brick and mortar type setting. And then, of course, the member or patient would be in any of these other places, whether it was a Department of Corrections, if they were in a local physician's office that needed a referral, if they were in a school clinic or our FQHCs, and even some of our public health departments, as well as some of the smaller critical access hospitals. So you see here where the member had to be in another type of healthcare facility, and then the physician whom they were receiving services from had to also be in another type of healthcare facility. And we'll see later on how that has changed during the public health emergency. Next slide, please. So CMS has provided us with some guidance during the public health emergency. And one of the things that they've done is that they've allowed states that we don't have to submit any type of SPA or state plan amendment to pay for those services via telehealth if those services furnished are made in the same manner as when the service is furnished in a face-to-face setting. And again, we were able to have that parity, so we didn't have to go through the process of submitting any sort of amendment to any of the services we provided using telehealth. So that was very good, and we were very grateful that CMS did provide states with that guidance. Next slide, please. So then what happened? Of course, everyone was scrambling. We had to develop some strategies around what we need to do during the public health emergency, and we'll talk about that in the next slide. Next slide, please. And so one of the things that they did is that they relaxed a lot of the telemedicine restrictions. Now, again, we have had guidance since 2005 and then additional guidance in the state in 2014 from the medical board, but CMS loosened a lot of those. So the privacy regulations, those have been loosened. They've also allowed phone visits. Before, those were not allowed. There had to be very special equipment that had encrypted software and things like that. Also, it allowed clinicians to practice across those state lines. Before, those physicians had to still be within the Georgia borders to practice that. That is no longer the case during the public health emergency. Also, members do not need to be at another healthcare facility. They can access those services from the comfort of their homes. The other thing is that they waived the need for pre-existing relationships. Before, the members had to already have seen this provider, they had already done an assessment, and so this would be a continuing of care. Now, if you needed to go see this doctor, you had never seen them before, even for your initial appointment, you could do that during the public health emergency. And then, of course, you see all the other things about widespread coverage and reimbursement. There was no cost sharing for patients. We had expanded the telecommunications infrastructure. And again, it could just be as long as there was some internet in place between both, and that was fine. And then, of course, what we hoped at the end of the day is that we would not put a strain on the health workforce and that we kept everyone safe. Now, it's also very important to note that these provisions may not be continued following the end of the national public health emergency. And so we'll talk about some things that we need to do if these relaxed restrictions are then put back into place. Next slide, please. So, of course, with the temporary expansion, that also included, again, our FQHCs, they could serve as a distance site. Our emergency departments could serve as a distance site. Again, the initial nursing facility and discharge visits, those could all be done using telehealth, home visits, as well as some therapy services. So that was an additional expansion of telehealth. And so we're very glad that we were able to continue to render those services to our members. Next slide, please. So the temporary health waivers also included that you would conduct telehealth with patients located in their homes, and we talked about that. And it didn't matter if it was outside the rural area or even in a metropolitan area, you were still able to conduct telehealth. You could practice that remote care even across state lines. We did have members that moved to be with family in some of our neighboring states, and they still were able to see their providers using telehealth. This also applied, again, as I stated before, to the established as well as the new patients. And then, of course, the bill for telehealth services, both video and audio, could be done as if it was in person. So we didn't have a reimbursement issue there. Next slide, please. So here is now the new model during the public health emergency. Again, as I stated, as long as there was a secure internet connection, not necessarily encrypted, but an internet connection that was stable, you could be anywhere and anyone could speak with each other. So not only do you have the physician, or if you were in another clinician's office and they had a diagnostic station that the member would sit at and, of course, read vitals and things like that, and that may have been sent to a physician for them to review and discuss with the member, they could do that. Also, you had specialists that during this, you couldn't bring those specialists into the facility or into the home, or you may not have been able to get into that practice, but they were able to communicate with the member. That information then went to your electronic health record, and you were able to go back and forth that way, as well as, again, any sort of telemedicine visit that you could safely do within your home, as well as the clinician, excuse me, as well as the clinician being in their home. So they also did not have to be in a brick and mortar healthcare facility to render services to members. Next slide, please. So again, one of the things that it was very important, and we had to make sure that we address this very early, is that services must be a member-initiated appointment and indicated in that treatment plan. And that was very important because we saw where some providers were doing some phone check-ins and some other things that didn't quite meet the criteria of a full visit and were attempting to get reimbursement. But this has to be a normal appointment that a member would call and want to have with that particular provider so that they could render services. So it must be member initiated. Now, what we've told providers that when they are billing, that if they historically did not bill the service for telehealth, they would use the point of service 02, which indicates telehealth. Now, those that already were able to bill their particular service using telehealth, they would continue with those modifiers of the GT, GQ, 95, and the other applicable modifiers as identified by their category of service, which was very important because what you might use in therapy, you may not use for a home health visit. So it's very important that everyone understands what they were able to bill within their respective categories of service. And so we made sure that folks understood that and definitely referred them to their policy manuals for additional resources, as well as their Gainwell provider reps. Next slide, please. And so after the PHE, where do we go? What do we do? How do we get back to normal, if we get back to normal at all? And so we'll talk a little bit about that next. Next slide, please. So we actually did a survey. We began that survey in actually June of last year to talk about what should remain, what worked, what hasn't worked, and are there things that Georgia could have done differently? And so we got some very interesting responses from our survey, both from providers and members. Next slide, please. And so, of course, we got from all sides that the telehealth is a very useful tool when applied correctly. Each specialty and service, we will definitely need to review that specialty or service to ensure that they can continue to practice in the manner that they can. We need to definitely establish or refine the protocols for rendering telehealth. Will there be an Office of Civil Rights HIPAA requirements? Will those go back to what they were before? What are the health and safety requirements? Are those services being rendered where the member gets full access to what they need? Is there an exclusion to the service? Are there areas where you simply just can't perform it? And then, of course, we want for all members to have this at their disposal. So even though we're offering telehealth, we want folks in rural area as well as our metropolitan area to have access to the service. Next slide, please. And so, of course, some post considerations, as I stated before, the population for that particular service is very important for everyone to understand who they are attempting to service. Maybe someone who is not as technologically savvy may not be able to negotiate back and forth on a tablet or a laptop. And so that's something that has to be considered. The services that are actually being provided, can you realistically perform the services? We received feedback around that, like can you do swallow therapy and things like that? And some said that you can, and others with perhaps smaller children who may not want to sit in front of a computer that long may not be able to do it. So that's something that has to be considered. The provider community, we will definitely take our cues from those provider associations and those accrediting bodies that simply say this type of provider cannot perform a particular telehealth service. And so certainly we will adhere to that particular guidance. Next slide, please. And so all of this policy guidance is in your telemedicine manual. You have it in each of your categories of service. And then also for behavioral health and developmental disabilities, you have a very specific instructions there. We do ask that you go there to refer to that. They have a very handy chart that is updated quarterly. And we do ask again that you look for those updates each quarter. Next slide, please. Okay. So now I'll turn it over to Valerie Sapp, compliance specialist, with some additional COVID-19 updates.
Hello and good morning. My name is Valerie Sapp. I am the compliance specialist within the medical policy team. Next slide, please. The purpose of this COVID update presentation is to provide an overview of the latest COVID vaccine updates and system changes to policy. During the presentation, I will cover the monoclonal antibody infusion therapy codes, the vaccine third dose and booster shots, and the preparedness needed for the end of COVID public health emergency. Next slide, please. This is a list of some of the latest monoclonal antibody infusion therapy codes used for post-exposure to COVID-19 for mild to moderate symptoms. This list is not all inclusive. The antibody therapy codes are currently, all of those codes you see before you are currently in the Georgia Medicaid Management Information System. The codes effective dates will range because some of the codes were actually given CPT codes and HCPCS codes prior to other codes, but we tried to lump them all together and submit them at the same time. But the dates from CMS will range from May to July 31st, 2021. If you are a provider that billed any of the antibody therapy codes and received a denied claim, the Department of Community Health, along with Gainwell Technologies, will reprocess these claims automatically. Therefore, there is no action required on your part. Next slide, please. The vaccine third dose and booster. DCH has received several questions regarding what is the difference between the third dose and the booster. The third dose is for people that continue to have a weakened immune system after the first and second dose. And the booster is for people whose immune system response has weakened over a period of time and received the second dose. All of the vaccines are available in gamuts. The third dose from Moderna to Pfizer's first and second and third dose. All the boosters are in the system. We currently have the children vaccines from age 5 through 11, the first and second dose. All those codes are billable, and they all are for Pfizer, Moderna, and Johnson & Johnson. And I know currently that they're working on a booster for 18 and over, just no restrictions, just 18 and over. So as soon as that particular code comes out and is available, we will also put that into the gamut system as well. Next slide, please. This slide contains the billing guidance for Pfizer and Moderna. Although Johnson & Johnson is in our system too, I just use this as an example so to show you that all the codes are in the system. And according to the CDC latest guidelines, eligible people that can receive the booster are allowed to mix and match the booster shots. But bear in mind that you cannot mix and match or that the vaccines are not interchangeable. So although you can have like a Moderna first and second shot, and your third shot or your booster shot you do have the freedom to mix and match, but you just cannot mix and match the first dose of Pfizer and the second dose of Moderna. But again, so please be informed that the boosters are the only ones that you can mix and match. Okay, next slide, please. The end of the public emergency. As we slowly approach the end of Georgia public health emergency and begin to return to normal operations, the provider community will need to receive, the provider community will receive notifications regarding the wind down of some of the temporary policy changes that we created during the public health emergency. Therefore, it is important to read your banners, provider notifications, contact your field rep if need be, attend all workshops. This will ensure that your office or your facility is aware of any timelines or deadlines as we slowly approach the end of the Georgia public health emergency and begin to return back to normal. So your banner messages and your provider notifications will keep you informed of the timelines and the schedule in which the department continues to slowly return back to normal. Next slide, please. Okay, are there any questions?
Anika, Rebecca, and Valerie. Thank you, Anika, Rebecca, and Valerie. We have 4 questions from the audience that I will read off and provide answers to. The first question that we have are therapy providers still allowed to provide telehealth services from their homes since the public health emergency is still going on? If so, when will this policy change to where providers can no longer provide telehealth services from their homes and need to return to the office to provide telehealth services? Therapy services are able to be rendered, therapy providers are able to render services as outlined in the Appendix K, 1135 and 1115 waivers from their homes during the PHE. Upon the expiration of the PHE, providers will be notified with specific guidelines to providers. Please review banner messages, remittance advice, notices, and provider associations and the DCH website for changes. Second question, can FQHC bill for COVID vaccine administration? We are having some difficulty with the CMOs paying vaccine administration. Yes, FQHCs can bill for all CMS listed vaccine administration codes. We are updating administration codes as they are handed down by the CMS accordingly. Next question. Is there a booster dose for the Janssen vaccine? If so, what is the code to use? The Janssen vaccine booster was authorized by the FDA on October 20th, 2021. The Janssen COVID-19 vaccine administration booster code will be 0034A. However, it is currently not open for use. The department is working to have the code updated into the system as soon as possible. Additionally, the next question is, why are the CMO plans not covering ambulance transportation for COVID positive patients using code U07.1? This particular question we will have to take back to the CMOs for further research, and we will add it to the FQHC document that will be posted to the GAMA site within the next 2 weeks. If there are no other questions, thank you so much for joining us for the COVID-19 update session. And once again, this session will be posted to the GAMA's portal under provider notices. Thank you, and you all have an amazing day.